afternoon, everybody. Excited for you all to be with us again on Thursday. This is the 6th of our 8 webinar series, and we're very excited today to have Dr. Kevin Sexton with UAMS, and he will be presenting our session 6 entitled Data Analytics, Metrics, and Reporting, Effectively Collect and Utilize this Information with Telemedicine. And I'm trying to get my slides to forward. There we go. So we are offering CE for this session. It has been applied for 1 credit hour. There will be enduring credit offered for this. So if there are folks from your health center that's not able to join today when we provide the recording, you can please share with folks within your office that you feel that would benefit from this, and they can also get CE credit for it as well. So in terms of disclosures, the planning committee as well as Dr. Sexton, we have no financial relationships with commercial interests. And the objectives for today, the learning objectives are learners will apply design thinking to data around data in telemedicine. Learners will be able to evaluate the actionable results from collected data, and learners will identify software and reference resources for data collection, analysis, and visualization. And Dr. Sexton provide a resource document with various links, and when I do send out the slides, I will also send out that document as well that you can share with folks at your listeners as well. So I'm going to move on, and I'm going to stop sharing. And Dr. Sexton, you can share your screen, but I'm going to introduce you at this point as well. So Dr. Sexton is assistant professor in the Department of Surgery, the Department of Biomedical Informatics, and the Department of Health Policy and Management at the University of Arkansas for Medical Sciences. He also serves as Associate Chief of Medical Informatics Officer for Innovation, Research, and Entrepreneurship at UAMS, and co-directs the Division of Healthcare Analytics in the UAMS Institute of Digital Health and Innovation. Dr. Sexton's clinical focus is general surgery, and his administrative focus is on developing technologies for market. He spends 80% of his time on evaluating healthcare technologies for implementation, co-development opportunities, and novel market potential for UAMS. Dr. Sexton has received research honors from the Association of Academic Surgery, Society of University Surgeons, and Association of Veterans Administration Surgeons. As an entrepreneur, Dr. Sexton has helped the technology for Credence Health, Inc., which has sold to ACS, a Xerox company, and is now being marketed as Midas Plus Live. Following this endeavor, he followed Medvisory, a private healthcare consulting company focused on algorithm and application creation. So we're very fortunate to have Dr. Sexton, and I'm going to turn it over to him now. Thank you.
And thank you, Lisa. Excited to be here today with you all. Thank you for the opportunity and the ability to speak to you this afternoon. So let's get started. I have to let the group know that I do have patents related to remote patient monitoring, and these are in measuring peripheral venous pressure to predict things like sepsis and shock. Unrelated to stuff that we'll be talking about today, probably the most important disclosure is I'm a huge data nerd. I love talking about numbers and math, and so if I get too in the weeds, you'll have to rein me back in. I hope not to, though. So I'd like to start with the opportunity to extend our lives by at least a few minutes today. Many studies have shown that folks that embrace a concept of gratitude tend to live longer than those that don't make this a daily part of their life. So take just 30 seconds and think of one or more things that you're grateful for right now. And I think this is so important now, particularly with all the stress that all of us are undergoing in the pandemic, to remind ourselves that there are things that we can be grateful for. And today I'm grateful for the opportunity to speak with you. To level set for the talk today, some things that I have found helpful in virtual presentations is the group chat. So Lisa and I both have a chat window up, and we're going to be monitoring that. One of the cool things about Zoom is you can go up to your picture, click the three dots, rename yourself to anything you want to be. You could pick a spirit animal if that makes you feel better. And then no one will know what questions you're asking, and we can have an open and honest dialogue. Because a lot of data and analytics, it's really about asking questions. And so I hope we can get some questions from the audience today. So now let's jump right into data. And data can be a pretty daunting topic. There are lots of types of data. When people think about data, they usually think about a lot of crazy math, where they're using more letters than numbers in the math. But when I think about data, I really think that data can be in anything we do and in any way that we interact with the surrounding world. Data can be accessible, meaning it's available in a computer. We can think about the matrix, and the data is enhancing how we interact with the world in real time, our technology in our pocket. The data can be stored in a library or someplace where it's difficult to access. And then we think about stock market data or trend data, where we're constantly afraid we're going to miss out on something because data keeps flowing at us quickly and more quickly and more quickly. And it's fascinating to know that in the last 10 years, more digital data has been created than has existed in the entirety of the human race. So the amount of data that is available is astronomical, but not all of it's useful. And sometimes finding the signal in the noise is a difficult thing to do. So I'd start by level setting on a couple types of data. When we think about numbers, math, and doing calculations, that's on quantitative data. You can express an amount, a range. This type of data defines a variable. A data that we're learning, another data type is called qualitative data. And this is traditionally things that approximate or characterize. This is usually data that you get from surveys and transcriptions. And it's extremely important when you're refining processes to think about both data types, because there's a quantitative outcome. Did you screen more patients for colon cancer? Did you increase the number of telehealth visits? But that rarely gets you to why. And so if you want to know why more folks are going to telehealth now than ever before, some of it's being forced from the pandemic, we have to ask them. And then in qualitative data, when we explore this, we're looking for something called theme saturation. So you don't have to survey thousands of people to get a defined answer. We have to continually survey folks until we're no longer identifying new themes and new reasons for things happening. And when it comes to data, it's all around us. I mean, look at this person's white coat picture. I don't know about you all, but I can't say that I have ever carried one of these in my pocket. This is a stock photo. It's from Pixabay. It's not real life. And you can tell that almost instantly. So same way with when you're talking to folks about data, it's really key to be authentic. And sometimes we just let the information speak for itself and have to come up with not the correct answer, but a viable answer for us. So our first foray into data, I want to introduce a concept called behavioral economics. And behavioral economics was made famous by the Behavioral Insights team in the United Kingdom. This is a group of people that came together to really understand how humans decide. And they mix principles from economics and from psychology. And this is a field that's been growing considerably in the last decade. It's explosive, and it helps us understand how people make choices. So, how many in the group send appointment reminders in some way? You can throw it in chat. You can use the emojis to give a thumbs up or a hand, whatever you want to do. I'm sure most of us are trying to remind folks about appointments. Okay, great. So you use software. We do text, call, my chart. Perfect. When we're thinking about how best to do that, it's amazing that what we say matters. And so in this case study in Britain, they wanted to increase the number of folks that were going to job fairs. The goal is to decrease unemployment rate. And one of the ways that they wanted to do that was increase the folks going to job fairs. And so there's two concepts here. They wanted to decrease unemployment. And so that is their lag measure, the overall goal and what they wanted to do. To do that, they identified a lead measure of getting more folks to go to job fairs. So when you're setting up projects, identifying a lead measure and a lag measure of interest can help you be more effective in assessing your interventions. So what they set up was a randomized controlled trial. And that sounds scary, but for this, it's just doing a simple message. But what you want to do is test two things so that you know which is going to be the more effective intervention for your group. And so the control message was just a simple fact-based message. I would get a text that said, my job fair is tomorrow at X time. The next message said, hey, Kevin, your job fair is tomorrow at 10 a.m. The third message said, hey, Kevin, this is Bob, your job advisor. I'm just reminding you that your job fair is tomorrow at 10 a.m. The third message was that with a good luck at the end. Now, which one do we think was most effective? Three. And it turned out it was 2.5 times more effective than control to make the message personalized to me, identify who was sending the message. Even if it were a computer, it still identified who was helping me search for jobs. And then good luck. So they added a human characteristic to it. And there was a dose response. The more personalized the message became, the more folks showed up for their job fair. So think about this in the context of how you remind patients for appointments. If you make it individualized, you can increase your success. And so there are 4 principles for behavioral economics when it comes to designing an intervention or collecting data. The intervention has to be easy, easy, attractive, social, and timely. And that makes up the acronym EAST. The cool thing with behavioral economics is there's no one right answer. And one of the criticisms of behavioral economics is that these studies are sometimes difficult to reproduce. But they're difficult to reproduce because people are different, and people that live in different geographic areas respond differently to messages and respond differently to technology and to other interventions. And so let's dig into each of these 4 steps and talk about some examples with data. And so, easy. To make something easy, you want to integrate it into the existing workflow as quickly as you can, with as few clicks as possible. One of my roles at UAMS is with the electronic health record. We're constantly building order sets and trying to decrease the number of clicks that our clinicians and staff do per day. We want to reduce hassle, and we want to simplify the message. There really needs to be a goal of clear, plain language in almost everything that we do. And so some of these things with being easy, for example, are we worked with our radiology colleagues to try and decrease the number of portable films that are being performed, because we want to decrease radiation exposure to our staff and our patients on the floor. So all we did was adjust the search so that when they search for a chest x-ray, the first one that pops up is the PA and lateral. You can still find a portable, you can still do a portable x-ray, but your top choice is the one that we think is the default behavior. And we made it really, really easy to pick that one. And surprise, surprise, more people picked sending their patient to radiology, and we had less portable films. The next idea is to make the intervention attractive. And so you want to get the user's attention or the patient's attention and design rewards for the desired behavior. And when I say design rewards, I mean you want that path to be as frictionless as possible. Considering sanctions is another option that's brought up in behavioral economics. However, I think it's less effective. We want to encourage our users and to design rewarding behaviors for them and not be punitive. Next is social. Last is timely. So we are social creatures. We usually enjoy interacting with other people. I myself am an introvert. I'm just as happy with being by myself with a book in the corner or my computer screen crunching on data. But we tend to go with the flow when it comes to a behavior. There are some great examples of using social norming to improve outcomes. And I'll give you one of my favorite ones, again from the UK, and this one's on getting physicians to pay their taxes. So just like before, the overall goal is to increase tax collection. And they designed 3 responses for the physicians. The first one that said, Kevin, your taxes are due, pay them by this date. The second one said, Kevin, your taxes are due by this date, and gave more personalized information on how to pay them, like with option 3 from before. But the last one added one statement. Kevin, most physicians pay their taxes on time. Your taxes are past due. Please pay them by whatever date. Guess which one was most effective? The last one. You made someone feel or realize that they were out of the social norm, and that caused them, but was associated with more folks paying their taxes. So anytime you can build groups or networks and encourage commitment to others in your programs or the data that you are looking at, you're going to have a more successful intervention. The last thing is timely. So you need to think about when people are going to be the most receptive in your instance to whatever the intervention is that you're looking at. People need to see the immediate cost benefit to their decision and help people plan their response for what decision you're making. So let's say you're working on a program for stopping smoking. It's hard to see the immediate benefits to someone's health. But if you set up the guidelines by at this amount of weeks, your cilia start working again, your lungs start breathing better and functioning, and then you go through all of the sequential steps that folks are going to, and the benefits are going to receive from stopping smoking, including the financial ones, you can increase quit rate. And now that's been variable. But for me, for Timely, so as Lisa said, my background is as a general surgeon. So if folks are coming to see me, they're usually coming because they need an operation or have a question of if an operation would help them. And in my particular practice, I deal with a lot of incisional hernias. So average quit rate around the country is low. It's somewhere around the 5 to 10% range. In my clinic for incisional hernias, I have a 75, 80% quit rate for smoking because I won't operate on folks prior to or for an elective procedure if they're smoking because of the increased risk of wound complications and other things. But when they come to me, they're very receptive because they're seeking a specific outcome. And so we found that this is a very timely opportunity to talk to them about stopping smoking. They're not coming to the surgeon to talk about smoking cessation. But for me, that's the best time to interact with them preoperatively. And the lead measure is stopping smoking. The lag measure for me is I'm going to have less wound complications and less wound infections. And I mean, it's all about me, right? No, it's about the patient. The patient's going to stay in the hospital for less amount of time and will be able to recover faster because they'll have less wound complications. And so now we're going to take an attempt at doing a poll of the audience. And we'll see if Lisa can fire up the poll for us to figure out why folks are using your website. Okay, and we'll give people a few seconds to enter in data. All right, and now let's see about poll results. Lisa, are any showing up? All right, so people use it for information. That's the main thing that people are coming to see your website for. Okay. Well, for us, so when it comes to data and telehealth, we want to start by making sure we understand our customer and the patients. And so one of the first ways that folks will interact with us at UAMS is through our website. So we ran a study through the Department of Surgery website to look and see why folks were coming to our site. Turns out the top page that they come to is for education, to see our residency programs. So we added no more content to our website. What we did was put residency or educational programming front and center and made it really easy to see. It was, we changed the configuration of the site. We actually removed data and tabs from it. And in doing that, we increased our traffic from 33,000 visits to 81,000 clicks over the same 8-month period. And then I learned about a term called bounce rate, which is where people click on a website and then immediately go somewhere else. And we took our bounce rate from about 35% down to less than 10%. So people were going to the right thing. And I'm bringing this up in the context of telehealth and doing data analytics because the website is something that we controlled. It's something that we knew we could change. And that's where you need to start, I think, because you can measure a ton of things. You can change many fewer things. So you if you can focus on what are we hoping to change, what can we understand in the context of our study, and then who is going to be making the change, our customers, staff, stakeholders. And this principle I'm borrowing from something called design thinking. And you look at this photograph, and by the way, all photographs in this are copyright free from Pixabay. Great place to get stock images for free if you're looking to use them in your website. I get, again, no financial interest, just find it's a good service. There's no way you can build a maze like this by just saying, I'm going to build a maze and get started. You have to plan. You have to think about how you're going to get the materials to the site. And the next guy that Tim Brown, he's the executive chair for IDEO, a design firm in San Francisco. I really appreciate their approach to design and how the goal of design is meeting the need or integrating the needs of the people, the possibilities of the technology, and then the requirements for your stakeholders and business. It's really a partnership. And for design, there is a set of principles to guide us through it. So empathize. We need to learn more about the folks that are going to be involved in the process. And this can be your employees. This can be survey based. It can be activity based of when folks are clocking in or using the electronic medical record. To help me understand our users, we have 2 programs for our electronic health record that measure when people are in a chart. If I have someone that's consistently charting every night between 9 and 10 p.m., that makes me sad. And I can then go and say, how can I help you get to the point where charting can be done in clinic? It also helps me identify best practices in our own organization so that I can disseminate those. And it's really important when it comes to empathizing that we're seeking to understand and that this is not judgmental. It's help me understand your workflow, help me understand the decisions that you're making so I can relate better and help come up with solutions. So definition or the defining phase are where you're trying to see what decision points are available to you, what options are, what are the challenges and pain points. And then my personal favorite is ideate and prototype. And this is where you get to sit down and come up with the different ways that you can adjust things. And it's the old experimental method that we all learned in school of create a hypothesis, test a hypothesis, and then measure the results. And part of data analytics is being realistic about what you can measure, getting consensus that from the stakeholders that measurement matters, and whether it be a lead measure or a lag measure, that folks have agreed that that's what we're going to look to advise us on change. And so now I'd like to dig into an example, starting with another poll. And so Lisa's going to fire this one up, and I want to ask the group, do you schedule digital visits in between in-person visits, or do you block off time for just digital and then just in person? And this is a question near and dear to my heart because we deal with it in the Institute for Digital Health and Innovation and clinical informatics all the time with scheduling. And I will extend the offer that if anyone has scheduling figured out and is perfect at it, I would love to learn from you. All right. Okay, so we got a split. Do you schedule digital visits in between in-person visits? 38% yes, 25% no, 38% not sure. Now let's poll one more time. Should we schedule digital visits in between in-person visits? Okay, let's see what we've got. Yes, and it depends. Well, and there's no right or wrong answer. It's whatever your ultimate goal is. So, thinking back to the design thinking process, what would be the goal of making that determination? If it's a financial goal and the goal is to improve productivity in the number of telehealth visits, that would be one potential solution. If the goal is to minimize the burden on staff and figure out what's best for work-life balance, that may be another solution. Also, you may be stuck on this one. You may not have the ability to mix in digital health and in-person visits. And so I can tell you from our experience, if you want to have the lowest no-show rate and the highest completion percentage, blocking out time for digital health visits made that straightforward, or I'm sorry, blocking out time had a higher completion rate for us. And so we went through the design thinking process and tried to think about how are we going to set up this project with digital health to make it easily attractive, social, and timely, looking at when should we schedule appointments. So when we're talking about scheduling, what time of day for digital health is the easiest? Is it when the clinician first gets into the office? Is it the after lunchtime? And so there's a lot of different ideas around this, and got a great comment in the chat that someone's worked in places that set aside telehealth visits during one part of the day only so the provider could focus on clinic visits at a different time. Yeah, absolutely. And then imagine if you're taking that time that you've set aside and then you give the clinician the opportunity to work from home for that time. You give them some autonomy and flexibility in when they schedule that. And so now you're using not only a more consistent time to drive the bottom line and get more folks in and more successful visits completed, you're adding to your staff satisfaction. And so that's sometimes how you can make digital health attractive to staff. It's great if they don't have to be in the office the whole time, and you can give them a work from home option, or you can create a designated space that's for digital health only, so you can make the user experience more meaningful. Because like for me right now, things that help with cameras are the amount of light that you have. And most all webcams have a processing algorithm that's dependent upon the amount of light they receive. My picture looks clearer on a given camera if my face is well lit. If my face is dark on the same camera, the computer's using more resources to try and bring things into focus. So there are lots of ways that you can try and adjust different experiences. And then when it comes to data for this project, how are we going to measure the results? We wanted to see what our completion percentage was going to be, because it's hard for some folks to use digital technologies for visits. Most folks are really comfortable with phone, but when it comes to adding video calls, that was more of a burden. And then what changes are realistic? We can change our schedule and we can block things off. We've learned it's much easier to block schedules in half days than it is to try and block in 2-hour or even 1-hour increments. It just takes a while for folks to settle into a rhythm. And then for tools, I'm going to show you one we use that's called Power BI. And that is a Microsoft tool. There are plenty of tools for visualizing data. And this one just has some dummy data thrown in it on the different types of video visits that we have. And what we were focused on are completion rates, and to see how we could maximize this completion percentage. And so it's just a pre-post study looking at completion percentage. And when you batch telehealth visits, the completion percentage goes up. And so we extrapolate that lead measure to hopefully be that our patients and our clinicians are having a better experience, but I don't have that data back yet. We don't want to survey someone every 2 weeks because you'll get survey fatigue. But we think we're making progress by encouraging folks to batch telehealth visits. But seems to be an appropriate decision for our institution. It may not be for yours. Now, one thing that is important with thinking about this decision and the analytics is something called context switching. So what we saw was a consistently higher completion rate when clinicians weren't task switching between in-person and digital health visits. And if you think about telehealth, it's like getting set up for an in-person clinic visit. But when you walk into the room, you have your internal checklist of the things you go down. Digital health, it's the same way. For this talk, I've got the chat window up on one side, my slides in the middle, a separate screen showing the presentation for you all, and then everyone's picture so that I can interact with you. It takes time to set that up between every patient. If I've got it and I can just keep rolling through, I'm much more efficient. And this author, Cal Newport, he's a computer science professor at Georgetown University. He writes a lot on distraction, and particularly with technologies and electronics. And so when it comes to data in telehealth and in medicine, you have to start somewhere. And the barrier to entry should be really low. You can start most simply with just looking at the number of visits that you provide via telehealth means. And here's some crazy statistics. So in February of 2020, 0.1% of primary care visits were done via telehealth. In April 2020, 43.5% of visits were provided via telehealth. And so this is something that's going to be here for the foreseeable future. And when we look at telehealth visits, here's what we see. There's a difference in breakdown between rural and urban areas with telehealth visits. The adoption in rural areas is not as much as in urban areas. And we don't know why. Is it lack of access to broadband? Is it a difference of opinion that these folks prefer in-person visits or prefer a different type of relationship? We just don't know. And I will tell you, in working in data and analytics, rural and racial and ethnic minorities are populations that are usually underserved by digital technologies because we tend not to use digital technologies as frequently, be engaged with social media profiles as folks in urban areas. And so there's a lot of things that we need to learn and know. And when it comes to the rest of the story on this time period, even folks that were high users of healthcare had similar adoption patterns of use. So using telehealth in about the same rate. It didn't matter if they were sicker or had more comorbidities. Rural always has a smaller increase than those in urban areas. One thing is that with the pandemic, the higher instance of positivity around the location that drove more folks to telehealth and telemedicine visits. And so to help try to figure out what's driving this change in rural health visits, I'll give you a sample of some data that we try and collect. So we collect visit data on time of day, was the visit completed, and these are passive things that come from our electronic medical record. And I would encourage you to explore what things are already being collected that you can monitor and observe and follow for trends through this time. For clinician data, we look at specialty. We also look at, some folks have a higher completion rate than others. And some of that can be batching visits. There's a great comment about you can have additional disruption in workflow and getting folks online and getting folks involved with visits. If you're switching between in-person and telehealth visits, it's also important to know your clinician's attitudes toward telehealth. It's uncomfortable for folks that are great speakers and love face-to-face human interaction. They're great off the cuff, to be now removed. Touch is a part of the healing process. And when you take that away, some of us don't realize, or I didn't realize, how much I relied on that. I mean, I'm a surgeon. An abdominal exam is like part of my soul. That's just going to happen. And there's not a great way to do that when you're talking to someone through a screen. And when we look at patient data, we surveyed folks in my surgery clinic. I asked them, how do you want to follow up? Would you like to follow up in person or via telehealth? Almost all say that they would just like a phone call or a telehealth visit. When you ask them for their initial visit, almost all want to meet me in person. Whether or not that's, I don't think it changes the outcome, but there's something about establishing a relationship that patients want to do in a way that is familiar and comfortable to them. And so when we come to patient data, we try and dig into not only the demographics, what age groups are using what technologies, et cetera, but getting back to that qualitative data of why do they prefer the things they prefer. Outcome data, for this, we measure completion percentage that we've shown, but then all of our standard quality metrics, and most of those are regulatory or driven by our quality improvement team to help us focus on particular areas. We also look at website data, who's interacting with our websites, what tools we're using for telemedicine, and we have solutions that are both integrated into our electronic medical record and solutions that just send a link so patients don't have to download an application. And then we look at how our users interact with the electronic medical record. And I'm not saying this is best practice or what you have to do, This is what we do in the context of being an educational and research institution to try and help learn what best practice should be. And this is an example of the kind of dashboard that we'll create looking at our different visit types, breaking them down by services for us. And then the takeaway message from here is that digital health is increasing. One of the most reliable methods for communication is still telephone. And then remember, we talked about rural area uptake. Here's what telemedicine visits look like in Arkansas for us and for patients that come here. You can see there's Northwest Arkansas and then Central Arkansas, and then some clusters around the larger cities. So we need your help. We need to learn about how to reach and interact with the folks in between the dots, because they're not using telemedicine at a rate that folks in the urban areas are. And this could be an equalizer in care, but we've not seen it yet. And now I'd be remiss if we didn't talk some about tools and how to do this, but the tools don't matter. It's however you can collect data, and you can do an awful lot with Microsoft products or Google products. So the top left symbol is Google AdWords, and that'll help you get all of your website data and figure out who's coming and for what reason they're coming to your website. Instagram, Facebook, and Twitter are other ways to run ads for programs. RedCap is a survey-based tool. You can use Google Forms, you can use Microsoft Forms to send surveys and collect data from patients. You have to make sure that you have the privacy and other things that are in place and that you're HIPAA compliant with how you're doing it. But it's a great way to get structured data back on targeted interventions. And most folks can deal with a survey link and give you some information. Crazy Egg is just something I throw in for fun. It creates a heat map of where folks are leaving their cursor or clicking on your website. So you can see exactly where they're reading and where they're interacting with your website. If you have education that you want to deliver that's interactive. And then here is a sample of a RedCap survey that you can make. This is what I use for my teaching evaluations. This is my actual teaching evaluation survey for medical students and residents, because I want information on how I get better. And I can send them this link. They can fill it out at the end of class. And I feel like this helps me become a better teacher, the same way that we get patient satisfaction surveys from our institution, and folks' comments are helpful to how we can change our practice. Now, this type of data is really cool. This is called Google Trends. And if you want to know what folks are searching for, you can pull up Google Trends and then narrow this down to the region that you're searching. And so I'm going to stop the PowerPoint for just a second, and then I'm going to share the Google Chrome tab. And so now you can see trends. And so let's see if we go to pregnancy. I can look at the interest by subregion, and in Arkansas, pregnancy is interesting. So let's dig into that a little bit more. We can see related topics, overall searches to pregnancy, but I want to see Arkansas specific data. Here are the most common metro regions that are searching. Oh, I got a message that folks are not seeing it. Let me try it this way. Let's stop share this. How about now? Okay. Then let me go back up one layer. So this is a search for pregnancy and the interest over time. Awesome. When I look, Mississippi is a little more interested than Arkansas. And then here are the topics associated with pregnancy that folks are searching for. But I want to dig into our state in particular. I can look at interest over time. It's relatively flat. I can dig into interest by area. And then I can look at what folks are searching in addition to pregnancy. And so as a surgeon, I tend to have some of these set up where they're focused on hernia and the things that I talk about. And people think that I'm a mind reader when I'll bring up topics like, if I were dealing with pregnancy, lightheadedness or vitamin C, because they're probably concerned about coronavirus and using vitamin C in pregnancy. It's a way for us to get insight into what people are interested in, what our consumers are interested in learning. And so Google Trends has a lot of healthy or helpful data to let you know what folks are searching for. And I've enjoyed learning a lot about people by what they search for in related topics. And so how do you get started? Well, you have to collect some data for regulatory purposes. Start with what you have. Ask yourself if any of that data can help you get insight into what your current interventions are and what you want to change. Go there next. What do you want to change? And create a list of the things that you would like to adjust in your organization. And then narrow that list by what can you change. Next step, say, what do our customers need? And what do they want? What change do they want? Refer back to the design school thinking process. And then when you're getting to ideate and prototype, make it easy, attractive, and social and timely. And then be willing to change. Have everyone agree on the lead and lag measures that you're going to follow and what time period you're going to reassess. Sometimes giving an intervention a week is not long enough. Sometimes it's 5 days too long. Pick the time interval that you're saying, I'm going to go back and I'm going to look at this. And if we're not doing as we'd hoped, we'll take another guess at where we should go next. And so now we've got 5 minutes left. I am happy to answer any questions that could come through the chat or respond to any comments.
Dr. Sexton, I'm going to open up chat. I'm going to open up the mics for everybody. If they're interested in making any comments or speaking verbally, they're going to be able to unmute their mics as well.
That's great. I'm tired of talking.
So folks have access to unmute their mics now, if they'd like to.
And if you're an introvert like me and prefer typing, I can see that too.
Any questions, folks, for Dr. Sexton? I think you really broke it down in easy to understand, steps on really interesting on things to consider.
Well, and what I'll add then, and folks can get tied up with tools. And for statistics, there are a ton of different tools. And there are a ton of different languages that you can learn. Excel can do a lot of things for you. And most of us use Microsoft products. If not, Google Sheets can do the same. If you're looking for help with statistical tests, most simple things can be done with a t-test or chi-squared, and you can do that in Excel or Sheets with an add-on. If you need help or have any questions in IDHI, we have a division set up specifically for healthcare analytics. So we help answer questions all the time. My email is pretty easy. It's kev@uams.edu. You're welcome to reach out to me anytime. I may not know the answer to your question, but I'll try real hard to figure it out.
We've gotten some comments here. You've probably noticed those. But everybody says that it's very interesting information that you've shared today.
And let me see. It looked like Mary Beth may have had a question because she was still muted.
Yes, and I've unmuted her. Mary Beth, would you like to, can you try again?
Yeah, thank you, Lisa.
There you go.
Thanks, Dan. That was really, really great. With a place this big, I don't know how it takes us so long to discover one another, but I know where you live now.
Perfect.
Yes, so you will be hearing from me, and unfortunately I have another call I have to hop on to, but thank you so much for the information, and I really appreciate Lisa for inviting me.
You're welcome. Happy to help.
Three additional messages, it looks like.
Yeah.
A lot of thank yous. Oh, we have a question.
I got a great question from how did you all convince clinicians or encourage them to use telehealth? And on this one, I will say coronavirus or COVID-19 shut us down clinically. And so it was like being voluntold. So our clinicians had to adapt. And I'd like to reframe the question in that adoption at UAMS mirrored other places. We had some programs that had readily embraced telemedicine, like maternal fetal medicine, but it wasn't widely adopted until COVID-19. What we did was try to make the user experience as seamless as possible once more folks were on telemedicine so that they consistently go back to that as a modality. And oh yeah, go ahead, Lisa.
I was just going to ask you, on the slide where you showed the uptake on telehealth with the urban versus rural, you know, do you have any ideas on some things that perhaps health centers or other providers in rural areas can do to increase that uptake in the rural areas? Because, you know, in the rural areas, you know, you have a lot of the social determinants of health. You have transportation issues, and you have a lot of the elderly population that, you know, it's difficult for them to get around or to drive in, and there's just so many factors. And so just your thoughts on, you know, do we just need more education? Do we need to be able to, you know, assist them in the home? How do we need to go about trying to improve that for those folks?
Great question. I think a lot of it is trying to fit our solutions to the needs of the patient. And so a telehealth does not have to be a real-time video visit for success. Telephone visits work, and what worked in my practice and what we're trying to figure out, because we don't know the answer to your question, is for me, it was moving follow-up visits there first because we had already had a relationship and folks were more accepting to it. So considering moving things like medication refills or chronic follow-ups, particularly ensuring before you recommend digital medicine that you have the tools you need to follow up. If you're looking at doing wound care, for example, you need to have the capability to send photos, or if you have a home health agency you're working with to manage someone's wound, have a way for them to get photos to you so that you can make the assessments you would normally do. And so I would start with simple visits with folks that you already have an established relationship, that know you, and that you are selling this to them as an increased convenience, because you're going to be talking about the same things via a screen than we would be in person. And then
Great.
I see a comment that seems like there are many steps to get set up as a federally qualified health center telehealth clinic. Regulatory is not my strong suit, but we have some great folks in our team. If you'll send me an email, I will connect you with them and answering some regulatory questions.
Great. Are there any last questions or comments before I do a little closing here? Well, Dr. Sexton, thank you for being with us today. Really appreciate the information you've shared. I know that a lot of this information is going to be very useful to the health centers. And since we are offering enduring credit and have been able to record this, I'm hopeful that a lot of the health center folks that didn't get to join us today will get to watch that and learn a lot from it. And, you know, you may be getting some calls perhaps. So we do appreciate your time, and thank you everybody for joining us today. In a few days, you'll be getting another email with campaigns, with the slides, with the resource information that Dr. Sexton has provided, as well as the recording, and very importantly, the evaluation. And we really do appreciate your input on this. We need your input and feedback. And hopefully everybody will join us next Thursday for our 7th webinar session on telehealth. So with that, I'll just thank everybody for coming and say goodbye. Thank you all.